Good afternoon, everyone. This is Shanka Ponsley and Dr. David Viquist.
Hello, how is everybody doing today?
Yeah, how is everybody doing? I think a lot of people are a little worried about the news about recession and all of that. And that definitely has to do, at least tangentially, with what we are talking about today. Because you and I, we have a passion of truly understanding healthcare, the cost of healthcare, and you, of course, I'll let you talk about your expertise and your passion for a moment, Dr. Viquist.
Thank you. As I suggested on the last time we got together, my area of research is primarily medical tourism, health tourism, wellness tourism, retirement tourism. Basically, people deciding to engage in patient consumerism in regards to healthcare and traveling sometimes outside of their city, outside of their county, even outside of their state or country to get access to healthcare how they want it, when they want it, and at the price they want it for.
Yeah, absolutely. So, and we'll talk about something today, which I think we'll come back to this book very often because it is called The Price We Pay. And Dr. Marty Makary did a phenomenal job of kind of breaking down a few of the internal workings of how medicine is organized and how the cost is established in medicine. And that is truly something that is deeply linked to medical tourism. And the topic that we're going to tackle a little bit today is overdiagnosis. And in his preface, actually, Dr. Makary says that over-testing, over-diagnosis, and over-treatment are now commonplace in some areas of medicine. So, of course, just wanting to make clear that it is not our intention to bash anyone here. There's a lot of systemic issues that are at hand when it comes to diagnosis. And of course, Dr. Viquist, you have some insight into that.
Yeah, absolutely. There was a really wonderful article many years ago by Dr. Gawande. Dr. Gawande, as some of you may know, was part of the failed kind of experiment that Amazon and, as I recall, J.P. Morgan Chase and Warren Buffett was putting together to develop a new healthcare organization that would somehow transform healthcare, and he was put in charge of that. He was a well-known physician, a faculty member, as I recall, at Harvard, and also had written several articles in the New Yorker that did exposés, if you will, of various different issues in healthcare. And he pointed out at that time, using physicians here in Texas that had similar types of populations, that there tended to be physicians, and this is primarily accessing government payer healthcare, particularly Medicare, Medicaid types of reimbursements, that there were two groups of physicians, and he had studied aspects of those two physician groups. I don't remember exactly what the two cities were. I think one was El Paso and one was another location. What he found was that the physicians that tend to do overdiagnosis, they tended to do overtreatment. They ended up approaching healthcare as a business, but not in the way that you and I know, not in the way that, for example, a DPC physician would practice it, but they approached it as an opportunity to make money to fund their other ventures. So in other words, they weren't committed, they weren't in it to win it. They were using the Medicare, Medicaid funding that they would do, and they would try to charge the government as much as they could so they could get money so they could put it into other ventures that they had. That was one of his findings. It was a really fascinating finding at the time, very controversial in healthcare. Since then, there's been many articles and stories and publications on it. One of the most interesting, I think, in terms of the whole idea of overtreatment, has been the development, particularly within the last decade or two, the increasing importance put on having a second diagnosis.
Mm-hmm.
So one of the companies that I follow in terms of healthcare that's doing some really fascinating, interesting things in healthcare, and is engaged in domestic medical tourism, and has been one of the forerunners in that, was Walmart. And a couple of years back, I think it was 2019 to 2020, they introduced that they had started a second diagnosis program for their employees. So they're one of the largest employers in the United States. They have a lot of lives that they're taking care of, and not only their employees, but of course the family of their employees. And as part of that, they found that sometimes their employees were being diagnosed locally in whatever location. So not casting dispersions on any location. Let's say it's an employee that is in Boise, Idaho. And in Boise, they had gone to their local provider, and the local provider, which may or may not have a lot of experience with orthopedic issues, for example, was diagnosing them and saying, "Oh, you need a spinal fusion surgery." So what Walmart was now doing, since they are self-insured, meaning that they pay for their own healthcare cost, is they were sending all the medical records electronically out to a specialist that was outside of Boise, Idaho, in a location where they received a lot of orthopedic um, injuries, a lot of orthopedic diagnosis, and they were re-diagnosing this, giving a second diagnosis. And Walmart's data showed that about 25% of these expensive diagnoses were being overturned, which is a phenomenal rate, much higher than most people would expect. So
Mm-hmm.
again, it's what we find is that oftentimes that just like in athletics, in medicine, people that perform procedures more often tend to be more knowledgeable in them. And
Mm-hmm.
so there's a role for expertise in medicine. There needs to be.
Mm-hmm. Yeah, and we have also heard of certain environments where physicians who are employees in a system, and they may be incentivized by sending a lot of business upstream. It's not something that should happen, and I know that most medical professionals would not act like that, but we definitely have heard of such environments where that was the situation. And that's why it's also so important. That's actually another topic in Makary's book, which we can talk about later. But this idea of measuring different providers, giving them some kind of way to be rated, if you will, that is also very important. But I remember I have a different health share now, but a while back I was part of Sedera, and they had, speaking about getting a second opinion, that was so important to them that, I forget the details, but if you went and got a second opinion, I believe you were basically guaranteed that whatever you needed to be looked at or treated for what was covered under their arrangement. So yeah, that is really, really interesting. And you did bring an article with you today that I think would also cover that, right?
That's correct. Yeah. So there's a 2018 article from JAMA, Journal of American Medical Association, that looked at precision medicine and overtreatment and overdiagnosis. And the findings are basically what we've known for a long time, which is the in decision making, that algorithms tend to be more accurate than a human intuition, if you will, or a human guess. And so precision medicine looks into things like genomic testing, which determines the actual DNA makeup of a particular patient, and then whether or not a specific procedure or specific pharmaceutical would be good for them. So, for example, there are cases where pharmaceuticals are less effective with certain people because of their genetic makeup, because of their ancestry, because of pre-existing issues that they may have or problems. And those actually are sometimes so complex that a individual physician that is trying to make that diagnosis on their own, particularly if their specialty is not in that area, they may be incorrect. And so therefore they would suggest a course of treatment which would not be based on this precision medicine approach.
Mm-hmm.
And so that's essentially the meat of it. This is obviously a major source of cost overruns. Going back to prior to the Obama administration, there was a report put out under the Bush administration many years ago that had suggested, and this was very controversial in healthcare at the time, that overdiagnosis and overtreatment, particularly when it came to Medicare and Medicaid, contributed upwards of 20 to 25% of the total cost in healthcare, and that was extremely controversial at the time. The Walmart findings, interestingly, are very similar. And again, Walmart has skin in the game. They're paying for these healthcare costs for these employees. If an employee gets a wrong diagnosis and they engage in an unnecessary procedure, and there's or a procedure that's not right for them based on their genetic makeup, then they pay the cost. And that employee is not able to come back to work as quickly, and they may have to go on disability or something of that nature. Walmart's responsible for that. So this 25% change difference is a major cost savings for.
Oh yeah.
And also it improves the quality for the employees. So it's truly a win-win.
Well, that really also shows we have spoken last time about those employers who are self-funded, self-insured. That definitely puts them in a situation where they have to be the captain of their own ship, so to speak. And I can see totally how having the science of genomics helping you basically understand whether what you plan for your employee is effective or not, how that can help. And I believe now that we speak of it, last year, I've met a salesperson who offered these testings at quite affordable rates to physicians. And he was also showing how it can definitely help prevent the physician from maybe prescribing something that the patient would be allergic to as well. So the science of genomics has many different applications that could be very beneficial.
Absolutely. And what makes it an area that I focused on or have paid attention to over the years is that we keep forgetting that expertise has such an incredible role to play in healthcare, and that expertise may not be in your region of the city. It may not be in your city itself, perhaps even the county, state, or even the country, that there's experts that could be elsewhere that could provide some assistance in your diagnosis or an assistance in terms of guiding your physician. Your physician is only as good as how well they keep up with the literature, because new literature is being written at an astounding rate. There's a center at Berkeley that pays attention to the amount of content and knowledge that's developed, and they've put out some statistics over the years that show that the amount of content that's being developed in any given area is in the gigabytes, and it's the trillions and trillions of gigabytes. So it's too much for most people to keep up with. My point is that a person that has more expertise, has more experience, having your physician be humble enough to reach out and work with these other experienced professionals would be very helpful. So it's if you will, virtual travel, because most of these meetings are teleconsults with somebody that may be out of your region or out of state.
Mm-hmm. Yeah, you know, that also makes me think of something that will actually hit employers in July, which is and I look it up here, it's the Consolidated Appropriations Act. I don't know if that is already on your radar, but we will definitely talk about that more in the future. In layman's terms, it basically puts the responsibility onto the employer to make sure that they exercise their fiduciary duties over the health plan that they offer for employees. So things like genomics and leveraging technology are going to become very important in this, because if you get audited, there is going to be an authority that will come and see and to check if you have done your due diligence, to see if all the tools you have set in place to keep your workforce healthy, if they were as effective as possible.
That's correct. You'll find this very interesting too in your area of work and working with the healthcare industry. Of not a very well-known study, but an extraordinarily good study was done in international medicine in Chile. And what they did was in Chile, they have a system where physicians need to practice in public facilities with the public reimbursements through the healthcare system for all Chileans. And then there was the private hospitals where the physicians that are trying to either make a little bit more money or establish themselves a little bit more work in. And these private hospitals tend to be have, if you will, a little higher standards in terms of the physicians that they'll hire. They just won't hire anybody. They tend to want to hire people that are going to give very good care. So it provided this wonderful, amazing case study, if you will, of looking at public outcomes versus private outcomes. And what they found it was like over 1 million patient records, and they were able to do essentially match pairs where they could look at patients that went into a public hospital that had essentially the same diagnosis as a person that went into a private hospital. And they compared the medical records and looked at medical outcomes. Really fascinating. And what we found, very similar to what we talked about in our last interview, was that the private hospital physicians, same physician that works in the public hospital, remember, it's the same physician working with different patients, one in a public setting, one in a private setting, appeared to be more meticulous in terms of what they would do with their patients, how they would deal with their patients. We believe, and this is what the authors believed as well, is that they were engaging in reputation management, meaning that they were paying attention to their patients, their family, listening when they were telling them perhaps problems that they've had before or their family history in terms of healthcare. And they ended up engaging in more precise, if you will, diagnosis and treatments, which led to better outcomes.
Mm-hmm.
And so we believe that this is a thing. We believe that incentives matter in healthcare and a person's reputation matters. So a physician that is essentially opening themselves up to the public, transparency, if you will, ratings on Google, the social media posts, things of that nature. A person that's opening themselves up is essentially going to be more aware that the way I treat people is going to essentially come back to me and could affect my reputation. So the physicians in the private hospitals appeared to be paying better attention to their patients, giving them a better diagnosis than they did in the public, where it was kind of like you were under a time crunch, and it was just kind of blow and go, and just kind of move through patients as quickly as you could.
Mm-hmm.
So really fascinating.
Yeah, we see that, of course, in the direct primary care field as well, where very often, in most of the cases, insurance is not part of the game, and then the name of the game is follow the money. And if the patient that sits in front of you is the one that actually directly pays you your compensation for your service without any middleman, that's a very different situation than when you can file a claim and it kind of goes through a system that probably to a large extent is also automated, and where, quite frankly, also fraud is possible, as you alluded to earlier. So again, we don't really accuse anyone of anything, but we're seeing these things and we're hearing of these things, and we believe that free market principles applied to healthcare can really be a blessing for everyone involved.
Agreed, and that's I'm with you. It's we're not saying that necessarily that the physicians that were taking these public reimbursements were necessarily trying to do a bad job or weren't trying to do the best for their patients, but it appeared that incentives matter, and they knew, working in these private facilities, that their reputation, both with this patient, their family, and then with the broader public at large, was directly responsible for them getting more patients in the future. So if you know that how you treat somebody is going to come back to you and potentially hurt or help you, those incentives tend to increase the overall quality of care, at least according to that research study.
Mm-hmm. Yeah. Well, the last question I have for you, and then I do want to stop a little earlier today to prepare myself for our next meeting, but artificial intelligence,
Mhm.
have you had any insight on how that can help with the better diagnosis or preventing an overdiagnosis?
So, Dr. Kahneman, hopefully I'm saying his name right, who is thinking fast, thinking slow, considered to be one of the most influential researchers alive currently, a Nobel Prize laureate. He is addressed in his thoughts about decision making, the role of healthcare, and has found all sorts of really fascinating things when it comes to healthcare. That, for example, the role of immediate feedback in the healthcare quality. So, for example, a radiologist that makes a diagnosis based on medical scans doesn't tend to get immediate feedback. In other words, they make a diagnosis that's then handed off to an oncologist who then works with the patient. And then as they go through further testing and further treatments, the oncologist then discovers, the true nature, if you will, of the cancer. The radiologist is separated from that ultimate decision, or the ultimate truth, if you will, about what's going on. So what happens then is that doesn't allow the radiologist to then improve upon their decision making, because they don't have that immediate feedback. They don't make the diagnosis and then hear back what happened. Oftentimes that communication is broken. So he suggested in cases like that, artificial intelligence is going to be better than human expertise and intuition, simply because the radiologist doesn't have as many opportunities to improve. Now, of course, that could be enhanced by, again, better communication and having that oncologist learn from their experiences by reviewing the case records of patients that they've diagnosed previously. So there's ways to overcome that. But in general, he suggests that artificial intelligence, using heuristics, using an algorithm, which was referred to in that 2018 article by Dr. Katz that we referred to and brought up earlier, those things tend to lend themselves to precision. In other words, they tend to lend themselves to a better decision-making process and thus better outcomes. I believe that algorithms, AI is going to improve healthcare significantly. It's going to be in certain areas of medicine. There still is a very major role for a physician. And I'm of the personal belief that the role of a physician is, particularly in, say, primary care, a person that is engaged and active with you and your family on lifestyle issues, as we talked about in our last article, the social determinants of health. I mean, just engaging in better nutrition, engaging in better exercise, and having a happy and healthy lifestyle, going outside and getting some vitamin D every once in a while. Those types of things will be much better for you. A good physician is a partner in your life and helps you to have better health by giving you advice based on the research. But when it comes to a diagnosis, for example, cancer diagnosis, having some AI in the mix along with a person that has seen you and talked to you about your lifestyle, that would probably be the best mix of all.
Mm-hmm. Well, it looks like, as always, the progress in technology has two sides of the coin, and if we utilize it in the correct way, it is by no means going to replace anyone. It's just gonna enhance and give more precision, give additional opinions. Yeah, for my part, I am leading a healthcare marketing agency. If you want any help with that, reach out. I'm also leading a movement here in San Antonio called the San Antonio Free Market Medical Association. If you are a physician or a vendor, supplier, employer who wants to look into that, please reach out. On your end, Dr. Wiequist, I know you are the founder director of the Center for Medical Tourism Research, and you're always looking for speaking engagements. And you also, I believe, said you are always looking for participants in research.
That's correct. Yeah, we are working with hospital systems. We work with regional healthcare clusters. We work with countries. We work with NGOs. We've done a variety of things. And if you'd like to learn more about the center, you can go to medicaltourismresearch.org. You can also find us on LinkedIn and on Facebook.
Awesome. Well, give everyone a like, follow the accounts if you see them. Definitely come back next Thursday and catch us for our next topic where we shed light on the inner workings of medical tourism and healthcare. Thank you so much for your time today, Dr. Wiequist, and we'll see you next week.
Absolutely. That sounds terrific. Thank you.
Bye.